I formally invite the ASI chairman for the presentation of the next topic, the dying clinical examination.
I have immense pleasure in introducing the president of the ASI, Professor PROBAL NEOGI. He is from Allahabad, a clinical teacher par excellence. Over to you, Professor NEOGI.
At the outset, I would like to thank the Kerala chapter for an amazing conference that you are putting up. And my thanks to the chairman, Srijan, all the ECs sitting here, Dr. Srikumar, Dr. Rajan, Dr. Ismail, Dr. Varghese, so many of, and Dr. Our main pillar of support for the ASI, Dr. Santosh John Abraham. I have no financial disclosures or conflicts of interest to declare. I bring greetings from the Association of Surgeons of India, headquartered at Chennai. We started off with a small membership of 112 some 85 years ago, and have come to become the second largest body of surgeons in the world, with a membership which has crossed already 40,000 and is ever increasing. We have 11 specialty sections and 26 state chapters. But today I'm going to talk to you regarding the declining art of clinical examination, the dying art of clinical examination in surgical practice today. There has been a decline in the physical examination skills. You may call it time constraint, you may call it technology that has taken over, or I feel it is the lack of confidence of doing a proper clinical examination which stops us from doing it. Of course, we teach our students through ward rounds, tutorials. Students learn on patients who give them appropriate stories. Faculty stand by to assess the required maneuvers the Holstedian way. Halsted went to Osler, observed Osler's way of examination. And in a landmark lecture in Yale on the training of surgeons, he formulated the Holstedian model, which was the art of passing knowledge to the next generation. That involves intense repetitive opportunities when the resident would acquire skills in clinical examination and formulate a plan for further management. The residents would acquire an understanding of the scientific basis of disease to take care of patients under the supervision of a skilled surgical teacher. But all that training can be undone the moment student realizes that there are easier, faster, and I dare say, lazier methods of just ordering tests. And that is easy. And the engine for all that takes place, where the dialogue takes place, is the computer. The consequence of losing faith and skill in that we miss simple things. We order more tests. There's increased reliance on lab investigations, and imaging has generated several problems that are a significant threat to patient safety. And that leads to incorrect diagnosis, to delayed diagnosis, leading to further tests, and that gaps in implementation of our guidelines. And that is worse in resource-limited countries like ours, where there's a huge financial burden and a waste of man-hours. I'm going to talk to you about this lady who came to our OPD with fever for 2 months. She complained of body ache, malaise, loss of appetite. She was tested for PUO, and she'd been to many specialists. But unfortunately, nobody had removed the scarf that she was wearing. And lo and behold, firm, discrete, rubbery nodes in the neck. The diagnosis was clear. Similarly, a 40-year-old man came with history of palpitations and nervousness. he was being repeatedly referred to a psychiatrist for psychiatric illness. And you just move the beard and you see a thyroid nodule. Ladies and gentlemen, these are not unusual stories. I am not opposed to new technology. I teach in a tertiary care center in a progressive country with cutting-edge technology. But I would like to make a case here. When you take a shortcut with physical examination and start ordering tests, we do not overlook the simple diagnosis, but we are losing much more than that. Physical examination is a key part of the continuum of history of present illness, to past history, to family history, and to extends to the examination and to the finally the diagnosis. I would like to introduce you to this gentleman here, having worked in Scotland, one of my favorite authors, Sir Arthur Conan Doyle. His fictional character is Sherlock Holmes. And Sherlock Holmes was based on his teacher. You know, Arthur Conan Doyle was a doctor. And he based it on his mentor, Joseph Bell. Joseph Bell had an eye of an eagle and the precision of a detective in which he could diagnose on physical examinations. I'll tell you a story. I describe a conversation. Imagine Joseph Bell sitting in his OPD surrounded by his residents, and a woman walks in. She says, "Good morning." Joseph Bell says, "What sort of a crossing did you have on the ferry?" She says, "It was good." Joseph Bell says, "What did you do with the other child?" She says, "I left it with my sister at Leith." Joseph says, "Did you take a shortcut to the Royal Infirmary?" She says, "Yes, I did." And then Joseph Bell goes on to say, "Do you still work in the linoleum factory?" She says, "Yes, but how do you know?" Joseph Bell turns on to his residents and tells them, when she says "good morning," I could pick up her Fife accent. Fife is a small island near Edinburgh. And the nearest crossing from Fife to Edinburgh was by the ferry. So she must have taken the ferry. She has got red soil on the shoes that she is wearing. She must have taken a shortcut through the botanical gardens which surround the Royal Infirmary of Edinburgh. And then look at her hands. She has dermatitis, which is typical of the linoleum factory workers of Leith. So just imagine how much of information this gentleman would have gone when he started examining this patient. I go on to the next gentleman, Leopold Aubenbrugger. He has been the one who he discovered percussion. He was son of a winemaker. His father used to send him down to the attic to see how much of wine was there in a cask. And he used to knock on those wine casks and see how much of wine was there. And that is how he discovered percussion. His book, Inventum Novum, would have gone into oblivion, but for a physician named Jean Corvisart, who was Napoleon's physician, he dug out for the world to follow. And Corvisart's junior was Laennec. And Laennec discovered auscultation, which is an incidental or an accidental finding. He saw boys playing sticks. We have all played that in our childhood, and hit one long tube on one end of the tube, and the other child would hear from the other end. And that is how, my dear friends, auscultation was discovered, accidentally or incidentally. And the stethoscope came to the medical armamentarium and causing a sea change in how we examine the patient, and it continues till date. I'm certainly not against the use of technology, but are we teaching our next generation to stop clinical reasoning? A research says that a primary diagnosis can be predicted from the history only in 74% of patients. And the prediction can go up as high as 90% or 95% when the physical examination is added to the history. And you'll be surprised to know that a pyloric stenosis in the 70s and the 80s would be diagnosed 85% of times by residents. And in the 90s, that number had gone down to 47%. So you can imagine what is happening in the 2000s. It is not only about diagnosis. What else are we losing? We are losing that tradition. We are losing that celebration of the doctor-patient relationship. We are losing that essential feature that forms the backbone of our relation with the patient. The power of the human hand, which not only diagnoses, it comforts, it supports, and it empathizes. A favorite picture I would like to show you, Tate of Tate Gallery fame asked one of his favorites, Luke Fields, to draw a painting depicting the condition of those times. This is talking about 1890s. Luke Fields had just lost his son, and he based his picture not only on the social times, but also as a tribute to the doctor who was treating his 9-year-old son who had just died a few days ago, and it was Dr. Murray. Dr. Murray, you can see on the picture, sat beside this child for 23 long days with attentive care, tending to the child. And you can see on the background the father of this child putting his hands on the shoulder of his wife, whose hands are clasped together in a prayer. So it's a tribute to the doctor who treated his son. If Luke Fields was to make the drawing today, this would how it would have looked. Discussion takes far away from the patient. Patient is replaced by the computer screen. So have we lost that communication? Have we lost that empathy? Have we lost that trust? Have we lost the consent in the quest for evidence-based medicine? This is the question I want to put to you. The real patient often wonders where everyone is, when they are going to come back, come by and explain things to me. Who is in charge here? There's a huge disjunction between the patient's perception and our own perceptions as physicians and surgeons. And this is where everyone is around the computer screen. Empathy is a desirable quality, as it is an important determinant of patient-physician communication. More accurate diagnosis and greater compliance to treatment. The secret to being a good doctor is empathy and the human touch, which we as technology-driven doctors are losing ground today. There have been critics, anthropologists, sociologists who have focused on the negative feeling of patients during physical examinations. They talk about invasiveness. They talk about anxiety of the patient during examination. They talk about patient discomfort. But unfortunately, there have been many studies which have proved the other way around. I'll share another story with you. A lady who is known to us. She was suffering from carcinoma of the gallbladder, which is a very common disease there. I had asked her to see a specialist in one of the metro hospitals. And I was surprised to see her back in my hospital after 10 days. I asked her, why did you come back? She was reluctant at first. But then she said, Doctor, it was a beautiful hospital. There was a valet parking. There was lovely music, young boys and girls helping around. But she said, they did not touch me. You would argue that there is no need to examine her. What is the need of examining her? We have diagnosed the carcinoma to the smallest molecular level. with all the PET scans and all the molecular diagnosis, why do we need to examine her? But to her, it mattered. It was enough to make her come back. And that speaks of the human factor and the attentiveness that she needs. Examining a patient is a ritual. Hold the hand, look at the pulse, look at the nails, look at the palm, the epitrochlear nodes, go to the supraclavicular nodes, see the conjunctiva, the sclera. It's a military drill. It's a ritual. Rituals are important in our lives. Rituals are transformational in our lives. Rituals, we believe in rituals from birth, from graduation to death. An examination of a patient is a ritual, and it seals the doctor-patient relationship. There have been massive advances in medical sciences. We've been seeing since morning everything that is on hold, Ray. But death is inevitable. Remember this patient who stirred my soul. And again, I'm going to share a story with you. Gentleman had an end-stage carcinoma with metastasis in the abdomen, with malignant ascites. I would come up to examine him in the ward every day, look at his pulse, look at his abdomen, auscultate his chest, and he would lift his shirt up and let him examine me. And that was a ritual that was followed for many days. But when he saw me on that would have been his last few hours on this earth, his hands moved in slow motion. It was the same ritual. He folded up his shirt. I did not decline. I examined him, palpated him, percussed him. I think surely he must have known by this time that it was as vital for me as it was necessary for him. Neither of us could skip this ritual, forgetting that the ritual had a meaning and had a singular message. And the message was that I would be there with him, always by his side, forever till his last breath. That is the power of the human hand, my friends. Thank you very much.
Thank you, Dr. Prabal NEOGI, for that thought-provoking, very energetic speech. Thank you very much.
Thank you, sir.
Thank you, sir.